We can see that her resting blood pressure is 109/83. Now, this is with heavy medication. Now, it's really important for her blood pressure to stay within normal limits. With her vascular compromise or mixed connective tissue disease, a combination of high blood pressure and an inflammatory response is a recipe for disaster. So it's going to be very, very important for her, us and her other healthcare professionals to monitor that blood pressure. If she has her blood pressure go up, there's going to be significant risk for a stroke, microvascular disease in the brain, or damage to any of her coronary blood vessels, and including things like abdominal aorta dissection. So this number is really, really important. Blood pressure gets tested randomly all the time, and people kind of ignore it and overlook it all the time. But for her, this could be the difference between a healthy future or a devastating outcome. So right now, her blood pressure seems to be within normal reference ranges. Her standing blood pressure shows that it's equal to her seated blood pressure. There wasn't any patterns of orthostatic hypertension. And this is a good sign that helps distinguish the fact that her episodes of dizziness she's complaining of is not associated with disorientation from orthostatic hypotension. So one of the key things to always evaluate is that if someone has any symptoms of disorientation, to check blood pressure in a seated position and then standing. Now, if they stand up and their blood pressure drops, it's really important to ask them if they notice any symptoms of disorientation. If they just feel lightheaded, then we know we have some vascular dynamics and some patterns that are typically found with dysautonomia, in which they can't control their autonomic nervous system. However, if it's really vestibular based, when you change positions from a seated to a standing position, and there's also disorientation, any symptoms of their body moving or the environment around them moving is most likely due to a central or peripheral vestibular disorder and not really orthostatic hypotension, where there's some type of abnormality with vascular dynamics. A long time ago in the world of natural medicine, they would use this orthostatic hypotension test to diagnose adrenal dysfunction. And this is absolutely not a test for adrenal dysfunction. This is really a test that measures autonomic dynamics. It's much more complicated than having this blood pressure drop and then giving people like adrenal nutrients and glandulars. It's a functional autonomic test that's very important. Now, her system is doing well. There's no drop in blood pressure, and her blood pressure is within normal limits. So that lets us have some degree of comfort when managing her overall health, blood pressure, and autonomic function. The pulse oximeter and perfusion index and the hemoglobin measurements were conducted. And so one of the things to notice is when you're looking at her numbers, her pulse oximeter levels were really low in the beginning. They were like in the 94%. This is why I asked her to take some deep breaths. Now we have to remember that she had 2 episodes of pneumonia in the past, and she has a history of respiratory issues. So sometimes when people get multiple infections in their lungs, they can get some scarring, and they can have some ongoing respiratory issues. Now, overall, her SpO2 levels are not the best. So our oxygen concentration, we really like to see it at 98 to 100%. So that's not where we like it to be. And then the other key things to look at here is that her hemoglobin levels are within normal reference range. That's a really good sign. If you look at her past medical history, there was a couple of incidences where she had anemia of chronic inflammation when she was having her autoimmune inflammatory flare-ups. So right now, we're not seeing any patterns of anemia with this test where they use electrical light and measure the count of hemoglobin concentration in an area and give you a really good reading that correlates very well with serum hemoglobin. And then her perfusion index was 2.9, and perfusion indexes, can range, anywhere from 0.2 and all the way up to, to even 4, 5. 2.9 is a pretty good number. Now, in her medical history, there were lots of symptoms of poor circulation, cold hand, cold feet, cold socks, which really made us concerned for her vascular health. So remember that endothelial nitric oxide is really important for vascular health. So right now, her blood pressure is okay, and her perfusion index, meaning the ability to push blood into tissues, is good, which will help her with recovery. And her oxygenation is not the best, but it's okay. So these are all good signs, and we're happy to see these within the normal reference ranges, especially since we're going to have some difficulty really supporting her vascular dynamics and health with things like ginkgo biloba and vipocytine, because she's on blood thinners, and that makes those types of nutraceutical applications contraindicated. So with her, we want to still keep an eye on her blood pressure on an ongoing basis. We definitely want to keep look on that perfusion index and that oxygen concentration levels. Do you have something on your nails?
Mm-hmm.
What is that?
The baby put nail polish.
Okay. Make sure you feel time. Sure you don't have some kind of nail disease. I'm gonna take a look at your toes here.
I got bruises, but that's from the medications.
So you've been bruising up since medication? Where else do you have bruises? I'm gonna give this to Ben. Ben, can you take these here? Okay, so you got bruises here, and
I got them everywhere pretty much.
here.
Thank you.
Do you notice which medication causes bruises for you?
This one. No, because I'm on so many. I've been bruised since the hospital, but I got bruised like this before too. That was one of the reasons why they tested me for the autoimmune, because I get bruises and they feel like almost like a bones.
So you had these before that medication? So
Right. And they get really instead of smooth, hard.
Okay. Now if I squeeze your arm really hard, would that bruise you?
Probably.
It would. So when we look at the examination of her nails, skin, and check her capillary refill time, we can see that she has white spots and injuries throughout her nails from banging things around all the time and inability for her tissues to heal. She has bruises in her arms and legs. And this is not uncommon once people start to go on steroids in combination with blood thinners. They have a tendency to bruise. It's also not uncommon with people that have connective tissue autoimmunity to be very, very sensitive to bruises. And I asked her a really important question: if I just basically squeeze her hand, would she bruise easily? And she said yes. So you'll see that all the time with mixed connective tissue diseases that are autoimmune in nature, and also with people that have antiphospholipid antibodies. They tend to have bruises and inflammation really, really quickly. Now, lots of different things can cause bruising that occurs with minimal pressure. Anything that impacts vascular fragility, things like deficiency of flavonoids and vitamin C, or typically associated for nutraceuticals that impact that, or just any kind of severe systemic inflammation in tissues and blood vessels can also be a factor there. So those were the key things to really pick up on in that part of the exam. You have any problems with your vision? Mm-hmm. What are you having with your vision?
When I get those migraines, I begin
Just
to
from the
double vision.
Okay.
When I sneeze sometimes, I saw stars. Like I know what that means.
Okay.
And there's a spot that keeps following me on my right eye.
Okay.
That one just started.
Christina may be complaining about is some symptoms associated with retinal detachment. So people that have retinal detachment, sometimes they'll get debris and floaters and sudden flashes of light. They even get a shadow in their visual field. And she appears to have some of those symptoms. So it's going to be very important to look at her eye. Now, in her medical history, she reports in the case review that she's seen an ophthalmologist a couple times, really when she started having migraines and eye pain. But it wasn't really clear if she had any clear diagnosis from the case review. All we know is that it's important for her to get a thorough evaluation and for us to find out what may be happening with her retina. It's also possible with anyone that has autoimmunity, unrelated connective tissue loss, if she has any kind of neurological autoimmunity, to see any issues with optic neuritis. Now, if the optic nerve is inflamed, you don't really get floaters or debris. That happens with retinal detachment, and sudden flash of light is one of the key features of retinal detachment. But when you have optic neuritis, one of the things that will happen is when the optic nerve gets inflamed, when you look at an image in front of you and you cover one eye and the other, one eye can see things a little bit, let's say red, and then when they look with the opposite eye and they just cover one eye, they can see let's say that right eye sees something purple and the left eye sees the same thing a little bit red. That happens when there's inflammation in the optic nerve that then changes the wavelengths that then hit the occipital lobe due to the speed of conductance with inflammation. Then you can get those two separate patterns. So those are things that we need to evaluate further to see what's happening with her mixed connective tissue disease in her eyes. Just going to check your temperature there. 89.6, 91, that's pretty good circulation. Pretty good. That's still pretty good. A bit less than your foot, but still pretty good. So when we perform surface temperature evaluations, the surface thermometer, we can see that the difference between our proximal and distal temperatures are pretty good. Usually you want temperature to be no more than 10 degree Fahrenheit difference between proximal and distal. So for most people, they may be a little bit of difference in temperature from like their shoulder to their fingertips, but if it's less than 10 degrees, I wouldn't be too worried about that. Then you also want to look at the temperature between the hips all the way down to the toes, and again, if it's less than 10 degree difference, so it's only, let's say, 4 degree difference from the temperature in the hips and the temperature in the toes, and that's pretty good circulation. So she has that, and this is a little bit different than what she reports on her case review file. Her case review file, she reports having cold feet all the time and really, really cold hands and poor circulation. And we always have to remember that we're really seeing a little window of her overall circulation throughout the day. It's very possible that as the day goes on that her vascular dynamics change. That's why it's really important to look at symptoms as well. But right now in the office, it looks like her circulation is good, her blood pressure is good, her perfusion index is good. So we want to monitor her symptoms and see if she's still having circulation issues. And the reason why that's so important to us is that her circulation is a expression of her endothelial nitric oxide. And endothelial nitric oxide is really what she has to have elevated in order to heal her arteries and to improve her circulation. So we're going to constantly look at her symptoms for circulation throughout the case follow-up, especially as we get into her vascular health treatment application. This one up here?
Yeah.
What bit you? Do you remember?
I have no idea. It was probably right before my pregnancy. I got bit, I'd imagine a spider or something, and it got really big and puffed. Okay. My mom just poked it and...
Your mom doesn't remember it was a spider?
No, she said that there was a little gash or whatever,
Yeah.
And so she just used a needle to suck the tube, pour everything out of it.
Okay.
But I got really bad fevers and stuff.
Okay. And then...
The mole, I have never gotten it checked.
How long has it been there? Has it been growing?
I don't know. I can't see it, so...
Since I've known her, it's been there. And
The same size?
About the same, yeah. But because it's raised, it's a little weird.
You need to get this
Looked at.
Okay.
So when to perform a skin exam, we can see a couple of things that are significant. One, we see a bite, and this is a really significant bite with a spider. And brown recluse spiders, for example, are a known trigger for autoimmune flare-ups. So we don't know what role that's played. It's probably not the major role in her, but we know it's something that we can see with the skin exam, so we have to ask questions about it. And then we can look at her mole. And when you look at a mole, you're always looking at various things. And this mole looks, for the most part, benign when you look at some of the features, but there's also some red flags that suggest that it may be cancerous. So the first thing you should do is when you look at a mole is just draw a line in the middle of it and see if the two halves look exactly the same. And for her mole is pretty much symmetrical. And then you want to look at the borders and see if they're irregular. And her mole has some irregularity to it, even though it looks somewhat symmetrical in the video. When you look at it a little closer, the magnifying glass, which we didn't get on tape, there was some irregularity in it, and there were some changes in color. So when I see a little bit of irregularity, some changes in color, it's a little bit bigger than 6 millimeters, and she's reporting that there could be some size change. He's reporting that it's always been there, but we don't know if it's really growing. In any case, there were some red flags, and I really wanted her to make sure that she had that evaluated and also had a biopsy. Once people's immune systems start dysregulating and there's chronic inflammation and they start taking corticosteroids, they're under a lot of stress, that can set up the stage for cancer and other malignancies. So those were the concerns when I was able to look at that suspicious mole. So when I did the examination of her neck, her thyroid gland, and her lymph nodes, it's really important for me to really feel her thyroid gland because she had symptoms of both hyperthyroidism and she has autoimmunity, and usually when you have one autoimmunity, you may have other autoimmunities. So you always want to feel to see if there's any general swelling in the thyroid gland. With many people that have Hashimoto's, there's some swelling that you can sometimes feel, and you can also sometimes feel swelling on one side versus the other. But her thyroid felt fine, there was no nodules. And then I went through and checked all of her lymph nodules, and there was no swelling of her lymph nodes. So those were all good signs. During the abdominal auscultation, the bowel sounds were normal. There was no abnormal sounds, and there was no sounds of bruit, which can occur with renal artery stenosis when there's turbulent blood flow going through the renal arteries. With her history of vascular disease, we have to be on guard and be suspicious of any type of arterial stenosis in any other region. And in this case, no bruits were heard in the abdomen that are associated with renal artery stenosis. I'm going to poke in here around your ribs. Does that hurt at all?
No.
Is that to be poking? I think sure. Okay. I want you to take a deep breath in and hold it. I'm going to get my fingers deep into your abdomen here. Push out. Blow all your air. Blow out. One more time. So during the abdominal exam, you can see that I percussed and I palpated, and then I went to really feel to see if there's any enlargement or masses around her abdominal aorta. Again, with connective tissue disease, there's always the possibility of also an abdominal aortic aneurysm. And in her case, everything felt normal. We didn't feel any growth or any abnormal palpations extended anywhere in the abdomen. There was no swelling or inflammation around her liver and pancreas. And once you start having lupus as a potential diagnosis, you're always worried about any type of inflammation or autoimmune attack against any of the organs. So her abdominal exam was normal. Turn your head to the right. Any problem with that?
No.
And then the opposite side. Any problem with that? Any problems?
No.
Dizziness? No. I performed a Klein's test, and I put her neck into extension and rotation. So this puts a lot of stretch on the carotid artery. And sometimes if the carotid artery is unstable, that may occur with early carotid artery dissection. Some patients will many times have symptoms of disorientation. You may even see nystagmus develop immediately. It's impacting blood flow to the cerebellum, and even deep neck pain may be reported. So with her, there's no indications of any of those things. Remember, she did have a coronary artery dissection, so this just was a test to look at carotid artery dissection. I also did auscultate her neck to see if there's any abnormal heart sounds, abnormal carotid artery sounds, any kind of bruise. So I'm just, as you can see throughout the exam, I'm looking for any other vascular insult that may occur with her history, since she has connective tissue, autoimmune disease, and patterns of lupus. Perfect. So we take a look at here. That's pretty good.
Thank you.
Just and then I'm not going to come today.
Okay.
Normal spirometry. So I performed spirometry just to evaluate her overall lung function. Remember, she had 2 episodes of pneumonia in the past year, and her pulse oximeter readings of oxygen saturation were in the 94 to 97%. So the spirometric reading let me know that her lung function is okay. And that's also important when we're just looking at her overall circulation and overall brain function. Remember, she has lots of symptoms of brain endurance problems and fatigue, and we always worry about oxygen delivery when we see those patterns. So the good news is that her spirometric evaluation and even her lung auscultation were normal.
Copy?
Okay, try the other nostril. Does it smell the same?
Mm-mm.
What do you notice?
Subtle, maybe chocolate.
It smells different than coffee. It smells like chocolate.
Mm-hmm.
You smell that?
Mm-hmm.
And then like the other side. You know what it is? Does it smell the same?
This one's stronger.
Okay.
Gosh, I don't. Chocolate?
During the olfactory examination, you can see we check her sense of smell. She's able to perceive scent, even though there's a little bit of difference between one side and the other, but that's not so clinically important. The key thing is she can't distinguish the smell. You know, when you smell something, your ability to remember how to associate that smell with other things you've had in the past is engaging the medial temporal lobe. Now, if you look at our brain region localization form, there are some significant symptoms of impairment. So once again, whenever we see a person that has chronic brain inflammation, like if you look at our brain region localization form, every major region of our brain seems to have some symptoms. And then when you have connective tissue injury, you're worried about potential small vascular disease injuries impacting areas. And she has had a brain MRI, but in early stages you may not see some of those slight injuries until they get more and more progressed. So in any case, these are signs, clinical signs, when a person can smell it, but they can't remember what that smells like. Then you're worried about integrity of that medial temporal lobe olfactory center of the brain.
No.
No? What do you notice?
The 15 looks different.
It's with a shade.
This one seems to stand out more. Like maybe like the font, if you were looking at a bold, maybe boldier than
More
this
contrast.
one. Yeah.
Let's contrast with which eye?
With the right.
Let's contrast with the right. Okay.
Seems to be bolder with the green is definitely bolder.
Okay. In this part of the exam, I have her look at some charts that are typically used to evaluate for color blindness. I'm not really worried about her having color blindness, but I wanted to have her look at the charts and start distinguishing colors. So remember, when you look at a history like hers, you're worried about neurological autoimmunity and potentially optic neuritis. So when people have inflammation in their eye, then they have different wavelengths that hit the occipital lobe at different times due to inflammation impacting nerve conductance, and you can see a change in color. So for her, there was nothing really that stood out. She had a little bit difference in perception of the boldness of the green, but usually when there's optic neuritis, like one eye will see green and the other eye may see, purple or orange or some different color of that type, or may not even see the numbers when you use a colorblind chart like that. Now, most people, when you have them look at colors and really examine one eye to the other, they may notice a little bit more brightness in one eye or the other, and that happens when the occipital lobe is firing a little bit more or less on one side. It occurs with most people. You can even check it yourself. You can look at a bright image, cover one eye and look at the other and see if one eye sees colors that are more vivid. And that's not a abnormal problem. That just, again, is related to function of the occipital lobe, or the firing rate of the occipital lobe. One side could be better than the other, and it could be different at different times of day. But we're really looking for any distinct, clear changes in color perception with optic neuritis, which is really why I wanted to do this test, and she seemed okay.
Okay, I feel it.
One time. Another side here.
Is it touching the eyeball or just the...
Yeah. So with the corneal reflex test, what we can see is that she actually has some absent or sluggish corneal reflexes. So when this test is done, you just take a light tissue and then touch the actual cornea, and you should have a blink response that occurs. Now, sometimes it looks like she's blinking, and sometimes it looks like she's not blinking. And the reason it looks like she's blinking sometimes is because my napkin is sometimes touching the skin around her eyelid, which is eliciting the response. But when I actually just touch her cornea, there actually is either a sluggish or absent reflex. It seems to be more on the absent side on the right, and extremely sluggish on the left. So when you're looking at me doing this test, you really want to pay attention to when the napkin does not touch any part of her eyelid and just touches her cornea. So this is an area that is involved with a reflex from the V1 sensory distribution of the trigeminal nuclei with cranial nerve 7 for facial muscles that cause blinking. And this is really in checking the integrity and evaluation of the mid-pontine areas of the brainstem, the lateral regions. And this is a little bit off, something to keep an eye on, and we want to compare this with other neurological exam findings to see if there are any types of significant abnormalities. But this is a suspicious sign that there could be some inflammation, injury, something going on in that brainstem region.
Yes. This one's sharper.
Okay, let's do it one time. Same word.
Yes.
Sometimes it. Same or different.
Just a little bit different.
A little sharper on the right.
Mm-hmm.
I'm going to have you pull down against your sternum. I'm going to have you compare it to your sternum. So this is what I want you to do. Which one feels more like your sternum? This one or this one?
The right.
The right feels more like your sternum? Okay.
The right.
The right?
Yeah, it's almost like it's cutting. Mm-hmm.
This almost feels like it's cutting?
Mm-hmm. Yes.
Okay, and tell me this.
Yes, like it's cutting.
Feels like it's cutting?
Feels good. Feels good. You can keep
Okay,
doing
but
that.
even this feels like it's cutting, huh?
Mhm.
Okay. These feel like really sharp and pricky, like cutting you?
No, not like the base and this.
Okay.
They were on my face and...
Okay. Your sternum's a little irritated. Let's see what's going on there. And this is just already red. Wow. And just turn the pinwheel.
Yeah, probably he had a sharp knife.
Felt like I was doing a sharp knife.
Mm-hmm.
Okay. Interesting. Okay. Very light.
Mm-hmm.
See?
Okay.
Same.
This one more. Yeah, that one's feeling like a little, like the cuts.
Like the cuts? Really sensitive?
Mhm.
Let's pull this up for you.
But this one's fine.
So let me ask you a question. If I go here and I go here, is that the same or different?
Mm. They're about the same.
Good. I can have it here and here.
Same.
But this is sharper you felt like?
Mm-hmm.
Or less? More lifelike?
Yeah.
Yep.
Yep.
Do you feel that?
Mm-hmm.
Tell me when it stops.
Stop.
Feel that?
Mm-hmm.
Tell me when it stops.
Stop.
You feel that?
Yes.
Tell me when it stops.
Stop.
Do you feel that?
Yes.
Tell me when it stops. So during the sensory perception exam, we can see that when we check her pinprick sensation with a pinwheel, remember this is the disposable pinwheel, so we always throw away our pinwheels after each exam. But when we do a pinprick evaluation, she has a clear difference between her right and left face. And typically when a person has a discrepancy, you have to determine if one side is actually down or if one side is up. And the way you compare that is by checking midline. But it turns out her midline is also extremely sensitive. So it seems like the right side of her face and her sternum are extremely sensitive and the left side is actually normal. It's almost like it's a hyperalgesia. So anytime you do an examination, you see a difference between right and left, then you compare it to midline. But in her case, we can see an immediate inflammatory skin reaction with the pinprick, which means that her immune system in her skin is really upregulated. So she really is having hyperalgesia that is impacting her skin. We really will have a difficult time just with this one test alone to determine if this is a nerve-related issue that's causing more pain perception, even though she has face pain all the time, or if this is just a perception of greater pinprick because her nociceptors in her skin are up to threshold because of the inflammatory response. And then later on we check vibration sense, and vibration sense is intact. And remember, pinprick testing with the pinwheel is evaluating C fibers, and vibration sense is measuring A delta fibers. C fibers are with small fiber neuropathies, not that she has a neuropathy, but the small fibers of the sensory nerve, and proprioception is with a large fiber, the myelinated fibers. In any case, it doesn't seem like she's any kind of neuropathy or neurological issue, but it seems like more she has patterns of hyperalgesia due to increased inflammation of her skin. Do you ever trip a lot? Do you fall?
Trip? Mm-hmm.
How many times? A week? Like, do you trip weekly?
Bi-weekly. I don't go anywhere. He always now guides me, but
So
Yeah,
when we're walking,
steps.
step, hole in the ground, I just point stuff out.
Because you're afraid she'll trip.
Yes.
But you trip almost every other week for sure. 2 weeks. Okay. You have any bad falls yet, or?
No, thank good. On my arms or like I try to catch myself.
Okay.
Nothing where I've broken anything. Thank goodness.
Okay. In this part of the exam, patient reports that she has some, issues with falls and balance issues, and her husband jumps in and says she's always got to be careful to make sure she's okay and has a clear path because she's very prone to falls. And if you look at all the different bruises that occur in her limbs, some of that is obviously her connective tissue disease in combination with steroids and blood thinners. But those can make her susceptible to bruising, but the bruising will only take place if she is falling and has some balance issues. So she has dizziness as a chief complaint if you look at her initial paperwork. So there needs to be some investigation. We'll have to do some tests here to determine what is causing her balance and instability issues. And just let your eyes relax and don't fix it. But just kind of keep them in the forward direction here. Perfect. Okay, you can see here with the pupil light responses that she has a normal pupil light response to direct light, and she has normal consensual responses. So it lets us know the integrity of her optic tract pathways are healthy, and this is one of the things that we definitely want to check because we suspect she may have some neuroinflammatory responses, and she has facial pain that appears to be of a neurogenic origin. So overall, we like to see those pupil responses and they're nice and healthy. I'm just going to shine the light right in the middle. Get your pupil light reflex. So this light is right in the center of the eye. This one's off a little bit, so that's a little bit of strabismus there. Okay. Do you ever see double without migraines?
Mm-hmm. Yes.
Okay.
They only started recently, before the heart attack.
So there are times you do see double vision just by looking at gaze. Is it a certain direction that you've noticed that causes?
I think so.
What direction?
Maybe looking to the right.
Okay, with the corneal light reflex, you basically shine a pin light to hit both eyes, and you want to see if the light is landing equally on each cornea, or if the light is found to be different on the left cornea position than on the right. Now, with her, you can immediately see that she has a little bit of a left head tilt, and that the light hits the right eye exactly in the middle, but the light hits the left eye a little bit off the cornea, and this indicates that there's some degree of misalignment of the eye or mild strabismus. And because of that, I want to ask her if she has any patterns of double vision. So if she has an eye muscle weakness, then she won't be able to have conjugate eye movement and move her eyes in synchrony to give her one clear image. So she'll have blurriness or overlap of some parts of her visual field when she looks at an object, which is what she appears to do. And the more important thing is that this is a recent onset, and this seemed to change after her heart attack, which lets us know that we're really concerned about function and integrity of areas in the brainstem where these ocular muscle cranial nuclei function at. This may feel like it's not normal, but this is your head actually centered right there. Okay, so don't move it from here. And then I want you to look at my finger. Look right here. There you go. So now hold my finger with your eyes.
Mhm.
Tell me if you ever, they kind of get blurry and you see like a shady second finger. Anything?
I'm okay.
Okay. Keep your eyelids. Keep your eyelids open. I want you to track my finger. This one down here. Do you have a hard time tracking this one in this direction?
Mm-hmm.
And then keep your eyes open. Easier on this side, or the same? Oh, look at my finger. Look at my finger. And then keep your eye right here.
It's harder on the right. It hurts my eye.
Hurts your eye?
Yeah.
When you do the right?
Yeah, it hurts.
The
There's
muscles.
pain. Yeah.
So with a cover uncover test, you basically cover one eye, look to see if there's any eye movement, and then uncover the eye and see if there's any abnormal eye movements. So there's a very subtle movement of her eyes when we uncover her left eye, and her left eye moves out a slight bit. So that's an uncover exophoria. So usually when you see that, there's overcontraction of the eyes that are compensating for eye muscle weakness. And when you have a person have their visual field blocked, then that compensatory mechanism to keep eyes synchronized goes away, and then you see that shift in the eye movement. So we'll need to do cardinal fields of gaze to really determine if we see any types of abnormalities. And what we can see is that when we go down to the right, there appears to be some haziness and double vision, which may explain why she's having that cover-uncover exophoria and why she's seeing double. And it appears to be a weakness of the right inferior rectus muscle, and that's associated with cranial nerve 3. So we know this happened after the heart attack. So this could be issues that are impacting blood flow dynamics to the brainstem. So those are some possibilities that we have to think about. Some of the branches to the areas of the brainstem, especially around the areas of the midbrain, may be involved. But it's too early to tell, and there isn't enough clear findings from this examination alone. And then stick your tongue out. Tilt your head back. Whoa. Say ah. And ah again. Relax. And ah again. Perfect. Little swollen tonsil on the right. No gag reflex there. So when doing an examination of the mouth, tongue, and gag reflex, we can see that her tongue is a little bit coated, and this can happen from the medication she's on. It's not uncommon for steroids to have a significant adverse effect on the microbiome, leading to a coated tongue. There's also many medications she's on that really may have an impact on her microbiome and also promote a coated tongue. And then if you look at her gag reflexes is normal, but there is a significantly swollen tonsil. And then when I get a chance to talk to her about that, she reports that she's had the swollen tonsil since her 20s, and she's been tested over and over again for potential infections every time she's gotten a physical exam. And they'd even asked to remove that tonsil for her for many times, and she never had a chance to do it. And at this point, it's just been there. So that's something important to look at in her overall history and her general immune function.
And the tonsil's been there for a while.
How long has it been there?
Years.
Just that right swollen tonsil, or both tonsils swollen?
Just the right one, always there.
Always
just
the right
that
one.
lump or tonsil. Yeah, every time the doctors see it, they want to get it checked to make sure I don't have infection or something. And nope, it's just my tonsil swollen.
So how many times have you been diagnosed with a swollen tonsil?
Oh, quite a bit, especially when I was younger. Quite a bit with tonsillitis or infection, and probably in the 20s. They wanted to take it out, but just no time.
Okay.
But I do better. I've done better with it. But I did get a throat infection this year in May.
Your eye. Okay. Do you ever get like flashes of bright light in your visual field?
I think that's what that light or something.
Like a burst of flash spotlight?
Yes, it's just so horrible. Like somebody just put a flat deer in headlights.
Okay. And then they wanted you to see the ophthalmologist, right?
Yes, I have an appointment.
Did they say anything about retinal detachment?
Yes.
What did they say?
They want to look at that. They want to do a full thing because
Yeah.
autoimmune can it cause something with
Yes.
the eyes, and because I was getting the migraines hit me behind the eyes
Right.
to see what's going on back there.
Yeah. So if I didn't know any of that, I would say you need to go get an ophthalmological exam. So you have some signs that you may have something with your eye connective tissue, with your retina, and you need like a specialist with the training and the tools that can go in there and look at it better. Okay.
That's exactly what they told me. That's why I had a schedule. And then last week, my lupus doctor, that's exact. She said, don't miss that appointment.
So right around your retina, you have like a little color and like a little gray on both sides. And that can sometimes happen as the retina's kind of pouring off. If that does happen, you'll get these like bursts of light. Yeah. You have that?
Yeah, I wonder if that's what that is.
Okay.
It's something's going on with my eyes. I know that.
So you have to go to the ophthalmologist sooner than later, as soon as you can. You got to go to the dermatologist. So when I get a chance to look in her eyes, I can clearly see that her retina is not healthy. And there are some clear lines that are suggestive of retinal detachment. There's also some concerns about the health and shape and borders of her optic nerve. So there may be some type of optic neuritis as well. Even though her pupil responses are intact, there's both the concern to evaluate her for retinal detachment, which can occur with connective tissue disease, and also just to have a better look of her optic nerve. So we'll have to see what the ophthalmologist identifies, but it was really clear that once I saw those changes in her eye, and then we talked to her, that her other physician had suspected that, and that's why that referral to the ophthalmologist was conducted. So they probably saw the same thing that I was able to see with the panoptic ophthalmoscope. gonna stretch. Okay, that's all right. So evaluation of her deep tendon reflexes and pathological reflexes indicate that there's no patterns of upper motor neuron disease. So this is always something that's important to check, especially when we see things like sluggish or absent corneal reflex and history of nerve pain and autoimmunity, that sometimes people have neurolupus, and neurolupus can lead to scarring and injury of pathways around her cord and even in her brain. Now remember that she recently had a brain MRI, and a brain MRI was normal, but you have to remember that it takes at least 60% of demyelinization before you get a hyperintensity signal on MRI, and subtle injuries are identified with a physical exam. But overall, her deep tendon reflexes were crisp, and there was no patterns of any kind of upper motor neuron disease, any pathological reflexes, or any patterns of clonus, which is all good. Now let me stop. Do you have a leg injury or anything?
No.
No?
No. Never.
Come on back.
Okay. Again?
Yeah. Okay, no leg injuries, nothing with your
No.
foot? Nothing with your foot?
No.
No pain? Besides your joint?
Just my joint.
So when you evaluate her gait, you can clearly see that she has an abnormal gait. And if you look a little bit deeper, you can see that her right hip has some significant problems. First of all, her right hip is externally rotated. She just doesn't have a proper swing and extension of her hip when she walks. So these types of patterns can occur with deformity of the hip joint. So she doesn't really report of any pain there, of any injury, but there's clearly something wrong with her hip. Now, when I didn't get a chance to record for whatever reason, we went in there and pushed some pressure on her right hip, and there's just very limited range of motion. So we know that there's some anatomical changes in her hip. So when you watch her gait, you can clearly see that there is some lack of internal rotation of her hip, her footstick, and external rotation. Her heel strike, her loading phase, her mid stance are all abnormal with how her foot hits the ground. And then when she actually gets into the push-off state, there's very little extension there. Perfect. Put your hands up. Play the piano as fast as you can. Nice. Okay, put your hands straight up. I'm going to touch different fingers. You can use that to touch your nose. Okay, close your eyes. And touch your nose with this finger.
Oops.
Okay, touch your nose with this finger. No. Okay, hands up. Go as fast as you can back and forth. Fast. So in this part of the exam, I have her do rapid movements of her arm to see if she has any type of dyspraxia, where she can't coordinate proper movements. Also to check her speed, if she has any kind of hypokinesia. And they all seem healthy and intact. And then we have her deferring to nose, and she is able to touch her nose. She has a little bit of misjudgment of space, but it's not significant. And then I have her do repeated supination, pronation very rapidly, and it's very good. It's almost symmetric on both sides, and it's smooth, and her speed is good. And these are all telling me that her motor planning areas of her motor cortex are working, her basic ganglia, direct pathway is working, where she has rapid movement and speed, and that when she does repeated supination, pronation, she doesn't have what's called dystitokinesia. So those all tell me that her lateral cerebellum is working. So her motor regions of her brain are good. And also, she has a history of dizziness, and when there ever is a history of dizziness, you always want to do these tests, which are good ways to evaluate cerebellum function, and everything is intact. One foot in front of the other. You're going to balance feet.
Okay.
Eyes open.
Okay. And walk?
Yeah.
Oh.
Okay.
Mm-hmm.
That's good. Come all the way back again. You can do it with your eyes closed.
Again?
Yeah.
The straight?
Yeah. Can you do it?
Yeah, hold on.
So in this portion of the exam, I have her just try to walk tandem across the room, and you can see that she's having a really hard time doing that. And this is typically what you find with balance and instability issues or ataxia. But since her cerebellum function is pretty good, it really seems like that her balance issue may either be proprioceptive, so we need to go ahead and check her feet for sensory information coming up with vibration sense and do a monofilament test. And there's also the possibility that her balance is completely off because she's getting abnormal input from her hip, from her right hip, which seems to have some degree of fusion that is occurring there. So these are potential mechanisms that may be impacting her balance.
Yeah.
Okay, a little quicker. Eyes
Okay.
closed.
Oh, my eyes closed?
Yeah.
Now. 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 Now.
Feel that?
Not yet.
Close your eyes.
Now. 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 Now.
Okay. Stay right there. Let me feel the vibration.
Yes. Yes. Yes.
You feel the vibration?
Yes. Yes. Yes.
So you can see here that I do a monofilament test, and the monofilament test is really a good way to identify large fiber A delta sensory neuropathies. And when a person can't feel the monofilament, meaning that you put this plastic thin like neat pin on her leg and have that bend, if she can't perceive that, that's a really good sign that she has some degree of proprioceptive impairment. That would explain why she may have some balance issues. But we can see here that her monofilament test is okay, so there isn't a pattern of sensory polyneuropathy impacting her proprioception, and it just seems like it may be coming more from the hip than anything else.